Hi, good morning, everyone. Good afternoon and good evening. Welcome to the final talk of the International Healthcare Simulation Week 2021. The title of today's talk is Reunite to Reimagine a Better Future. Thanks for being here today and for celebrating the Healthcare Simulation Week together with us. My name is Asit Misra and I will be moderating this session today. Let me take this opportunity to briefly introduce myself. I'm a member at large of the Media and Communications Committee of the SSIH. I work at the University of Miami Miller School of Medicine as an assistant professor of surgery, Division of Emergency Medicine. I'm also the assistant director of the pre-hospital and emergency training division at the Gordon Center for Simulation and Innovation in Medical Education. It is my pleasure to introduce our speaker for today's talk, Dr. David Grant. David has completed his undergraduate studies at the University of Stellenbosch in South Africa before training in pediatric intensive care in South Africa, UK, and Australia. After his appointment as consultant in pediatric ICU at Bristol Children's Hospital in 2004, he began using simulation as educational tool. Simulation became his passion, leading to appointments as director of the Bristol Pediatric Simulation Program in 2007 and chair of Bristol Medical Simulation Center in 2009. In addition, he has served in multiple national and international leadership roles, such as Associate Dean of Simulation and as president of the International Pediatric Simulation Society and the Society in Europe for Simulation Applied to Medicine. He is a clinical academic at University of Bristol Medical School, where he has roles in both undergraduate and postgraduate programs. At undergraduate level, he leads the curricular integration of simulation and interprofessional education and leads the patient safety, quality improvement, and world of work helical themes. At postgraduate level, he is program director of the Masters in Healthcare Management and postgraduate certificate in healthcare improvement programs. He remains actively involved in simulation education at local, regional, national, and international level. He continues to collaborate with healthcare professionals in a variety of healthcare settings worldwide to establish local sustainable simulation infrastructures that enhance patient safety and quality of healthcare delivery. Over to you, Dr. Grant.
Good morning, good afternoon, or good evening, wherever you might find yourself in the world. My name is David Grant. I'm a clinical academic that lives and works in Bristol in the United Kingdom. I work clinically in pediatric intensive care at the Bristol Children's Hospital, and I am the simulation interprofessional education lead at the University of Bristol Medical School. I want to take this opportunity to thank Dr. Kelly Bryant and the Healthcare Simulation Week team for giving me the honor to address you this morning regarding some of my reflections on the pandemic, the impact on simulation, and also what it might hold for us in the future. I wanted to start by firstly acknowledging the role that simulation professionals have played during the pandemic. I've been absolutely blown away by the selfless way in which they have helped to prepare clinical staff to deal with unprecedented situations that for most of us we could never have imagined. And in particular, I wanted to sort of acknowledge that the level of innovation and collaboration across the world has been previously unseen and really has led to significant improvement in the ability of clinical staff to address the pandemic. As I said, I live and work in Bristol, and my organization delivers clinical care across 5 sites by around 14,000 staff. And that organization is serviced by the Bristol Simulation Services, which consists of a simulation center and 2 point of care simulation arms. So the Bristol Adult Simulation Program and the Bristol Pediatric Simulation Program. And our delivery model is such that we deliver between 85 and 95% of our simulation activities at point of care where we deliver the care to our patients. And so as you can imagine, both in a clinical setting as well as the simulation services, COVID has had a significant impact on the ability for us to deliver both of those services. And so what was certainly true for us, and I'm sure it's all over the world, is the phenomenal ask of us to be nimble, to accommodate rapid change within our organization, to ensure that we deliver the best possible care and services to our stakeholders. This idea of continuously learning, unlearning, relearning, and going through those processes and procedures continuously was certainly significantly taxing for us, and I'm sure it was the same for yourselves. Our simulation services staff, as in many centers around the world, consists of both clinical and non-clinical staff and so for the clinical staff, the change certainly during the pandemic, in the first instance, a large proportion of them were redeployed into the clinical services. So, which had meant that there was a contraction, if you like, in our simulation staff that normally exists. Our non-clinical simulation staff really stepped up during this pandemic and put themselves in a selfless fashion in harm's way to try and help and address the needs of their clinical colleagues and the organization to address this unprecedented problem that laid ahead of us. And so that very fact was certainly one of the stimuli that prompted myself and a group of colleagues led by Dr. Christine Park to publish last year the Simulation Manifesto, to acknowledge this significant impact of the pandemic on the non-clinical staff and also the risk to them during that pandemic. So overnight, our simulation services basically completely rechanged. Our simulation center retooled to become a vaccination center for our organization. And the point of care simulation programs and arms completely changed what they delivered. And so they reimagined their sort of task, if you like, where their role within the organization, and tried to be responsive to what was most needed at the time. So certainly when we started, what we found was that what was most needed by the organization as we surged into new areas of critical care to ensure that we systems test those new clinical areas so that they are safe for delivery. Helping staff who are not used to working in those environments go through systems testing and reevaluation of their sort of working environment to ensure that they were comfortable to deliver care in very testing and challenging conditions. A large proportion of the activities of the simulation point of care simulation programs were also to ensure that staff were competent in donning and doffing, which certainly for many of us were a re-rehearsal of previous pandemics, but certainly nothing to the scale that we have. In some instances, they needed to simply do what was most needed at the time. So I'm sure for you it was similar, that every week there was a new form of mask that was being introduced depending on what was available. And so making sure that all staff were fit tested so that they could safely care for patients was certainly one of the elements that they helped us address within the organization. And so I've mentioned many of the challenges that COVID has brought, and certainly undoubtedly one of the most challenging situations was the need for us to respond in a very short time frame to address needs that were evolving, systems that were changing, and constantly in this flux of change, and having to be adapted to that. Despite that, I believe that there's been significant benefits from the process of our organization having to respond to that. So certainly what we have learned, or the process of learning as an organization, this ability to rapidly adapt and implement change, is something that the organization will take forward. And I believe that it's an important part of helping us to move to what we have certainly strived for the last few years to get towards this nirvana of being a learning organization, that ability to deliver services whilst you learn and then adapt to ensure that you deliver those services safely. So certainly, I believe that COVID has helped us to learn or pushed us to learn some of those processes that's required to do that. And in fact, I believe that COVID has been a catalyst that helped us or forced us in some instances to reimagine the way that we deliver simulation-based education. So at least in our setting, we've seen a significant expansion in the delivery of virtual reality simulation. In fact, distance simulation has become a norm or a mainstream form of delivery of simulation, with publications on how to deliver those distance simulation events, how to debrief them. And so I think as a simulation community, we've embraced that change and really come up with significant sort of ways to address those challenges. I want to pause for a moment to look at our new reality. And so some of the things I wanted to address or highlight to you is not necessarily a new reality, but I guess a refocus on the reality. And that is that healthcare delivery remains to be one of the highest risk activities that our patients engage with on a global scale, and significantly contributing to their morbidity and mortality. Despite numerous initiatives over the years and patient safety initiatives that we've seen rolling out, patient safety organizations, it strikes me that the figures remain stark in terms of the impact on our patients. So when some of the latest figures being published showed that annually there is around 43 million patient safety events that occurs globally. And of those 43 million patient safety events, around 23 million disability adjusted life years are lost per year. In fact, if you live in a low middle income country, you're 50% more likely to encounter a morbidity or mortality related to your access of healthcare. Those are stark figures. And in fact, most of us believe that those figures are underreported because of the fact that they quite simply, they're not acknowledged or reported. And so the problem may be far worse than we anticipate. And quite frankly, I think that it's not good enough for us, the privileged of us who sit within organizations that have well-developed simulation centers and facilities, to just look after those who sit within our ivory towers. We must and we can do better. And so in fact, I challenge you to reunite and reach out. Create links with areas where there is simulation services are not established. Help them to establish self-sufficient, sustainable simulation services within their organization. Reach out and establish distance simulation and distance faculty development that helps them adjust their simulation to their local environments. I know many of you are already involved in that, but I'm calling for all of us to do that, because without doing that, we will never address the global impact of healthcare on the very ones we try and serve. I want to call on you to Cascade. So many of us work in organizations where we still struggle to deliver simulation in a significant way to all of our healthcare staff. And so with these new ways that we've reimagined the delivery of simulation-based education, I want to call on you to make sure within your organizations that each and every one of your staff members has access to high-quality simulation and team-based training that helps them to deliberately practice to do better for when it matters. I want to call on you to change and be part of that change and transform. Recently, I've heard continuously the words used such as resilience, and coupled with resilience, a multitude of well-being initiatives that's being rolled out. But the harsh reality is that unless we see organizational change at a level that really impacts and helps our staff to improve their working environment and the systems within which they work. We will never address staff burnout through any of these well-being initiatives that are well-intentioned but misplaced. What really matters is making sure that our staff are not put in situations that causes the burnout in the first place. And we as a simulation community have a significant role to play in that. I want to call on you to implement significant programs of proactive systems evaluation and redesign that helps us create the working environments where staff can implement work as done, not as imagined. So in summary, I want to thank you, and I believe that the future is bright and that we can and must be part of the solution. I want to challenge you to reimagine, to reunite, to reach out, to cascade, and to change and transform the healthcare for the patients which we serve and the staff that we educate. Thank you very much for your attention, and I'd be happy to take any questions if there are any.
Thank you, Dr. Grant. Thank you for this really reigniting talk, and kind of gives a fire to start thinking on what we can do and how we should take the next steps. Would you like to add on to a few of your points? Especially, I would like to hear more on how, as an international community of practice, we all, as who are invested in simulation-based medical education, can reach out to different stakeholders in the government. Are there any examples that you have used to as an advocacy so that the government can invest more? And I have seen that as a bigger challenge in low and mid income countries, because I started my simulation career in a LMIC, and I know funding and support for simulation based education was the biggest challenge. So if you can elaborate something or put some light on that.
Whoever's playing the bingo, you've got the first one. I forgot to unmute myself. Yeah, I mean, I see it, that is a really key question. I think, unfortunately, over the years, or certainly the early years, authorities have been divisive in setting us up as competing with each other for funds. And so what's happened is we've had, and my simulation center in Bristol is a great example of that. In the early 90s, we had one of the first simulation centers in Europe. And rather than at the time focus on establishing simulation-based education in every organization that delivers healthcare in our region or in our country, we focused on teaching others at our center. So come to the mountain to be taught. And that mentality, I think, is one of the things that's hampered us. What we have to realize is that, and this is a personal belief that I think many share with me and many would disagree. I think that, I once said this at a national meeting, too much rebuke, but I think the days of large simulation centers that need to be built for every healthcare organization are dead. We need to figure out how we make sure that each and every healthcare organization, so almost if you're planning to build a new hospital, within that you have to plan, where does your simulation services sit? How are those simulation services going to integrate into your governance systems within your hospital, into your education, that link between education and governance? The days of saying we've delivered a simulation and we've taught 50 students and we ask them how much they like the biscuits and the coffee and the tea, and therefore it's a success because they liked it, are over. We need to show impact, because other than that, we are never going to convince those who lead us that our endeavors are anything other than a sort of a passionate sort of group of people. So linking that and having the courage to say, actually, we've delivered this education, but we've changed nothing. Therefore, we need to go back to the delivery model. Because simulation isn't the answer for everything, but simulation combined with other things. And so this idea of hybrid thinking. And so to get back to your question, there's two things. So whenever I've been very privileged in working with some wonderful, talented educators in parts of the world that I guess you would call low middle income countries. And without a doubt, the resource constraints is so stark that because they've been taught over the years that simulation is all about the mannequin. And so therefore, if I can't purchase a mannequin, I'm not even at the starting block. And actually thinking about what we as a simulation community espouse to our sort of colleagues globally, what's needed, but sitting down and actually deconstructing and making sure there's an appreciation that it's about the modality of simulation and what that modality can bring, then allows you to do. I've talked about the outreach simulation. It's always on my agenda to meet whenever I go anywhere to help establish educational programs. Part of that visit includes meeting with leadership, both within the government and within the organization, because you don't know what you don't know. They have no idea what simulation can achieve because it's always perceived as a pure educational tool rather than a change mechanism. I always tease and call it the Trojan horse. It's the vehicle that gets us in the room to have the conversations that changes the things we're all driving at, which is to deliver safer healthcare. So I think I've not purposefully tried to be evasive, but I think it has to be a combination between understanding what it is that we're trying to address, bringing those senior leadership on board, and sometimes doing the things that maybe not on our bucket list, but is a problem for the organization to solve, so that they understand the impact of it and the funding comes to do the things that we as educators might want to do.
Thank you. I mean, I get that point that linking the outcomes and impact and demonstrating them might be a good idea at this point as we are progressing as a community. I have a question from Kelly, and she has asked us, like, now that you see the benefits of distance sim, how do you decide which modality to use, like in-person versus remote sim, and what are those deciding factors?
Yeah, that's a great question. Thank you, Kelly. So I will put my hand up and say I was one of the first persons that people that when they said to me distance simulation, I said distance simulation, shrimulation. How can that work? Simulation is about small group activity, getting around the bed and or the patient and as a team learning to work. And of course, what I forgot within that moment of thinking about it, my journey as a learner, which is continuing, is different from others. And I think the answer to Kelly's question lies in really understanding where the learner is. Undoubtedly, what distance simulation has allowed us to do is to be that. So there's several elements to it. I've seen distance simulation where the teams are sat at home, and it's a cognitive exercise in terms of rehearsing cognitively, not in terms as a cohesive team, the management of certain conditions. And that's that sort of what I call animating the textbook. So we've taken it from a textbook and now there's a practical example, but it's no different from, I think in that setting, to having some of the screen-based simulation that requires you as an individual to make decisions and the responses to that. And then I've seen, and actually some of my colleagues in India from Petty Stars, who's a wonderful organization that I know you know some of the leadership as well, Asad. They really took the bullet with us and took the lead on this, together with the guys from CHOP, with Vinay Nakani, who's always involved in everything. And really started looking at what does it look like if we have a group of faculty, if you wish, sitting in CHOP, and actually we run a simulation that they look at and they control the mannequin from CHOP, if that makes this, or at least the vital statistics that the team sees on the other side, and then debriefing it. So, and that was my point that I was trying to make. I think with the way that these guys have really started figuring out exactly how to work and can teach the rest of us to do it well, there is an opportunity for us to not, and we keep talking about international borders, but I work in a tertiary center, pediatric intensive care unit. It's an opportunity for me to, whilst I'm, in terms of time saving, not having to travel, with my partners who work in secondary care hospitals in my region to actually rehearse some of the treatment and give them feedback in a way whilst they're simulating that we hadn't considered before, because we haven't needed to. And I think by reimagining those kind of things and really understanding what it is and adjusting all of these new techniques that are starting to appear, I think what we will finally be able to do is cascade simulation. Because I think one of the challenges for me still remains in an organization that serves 14,000 staff. To employ enough simulation faculty to teach those staff in a meaningful way in the old way that we have is almost impossible. And so I think with these new techniques, not only can we improve the service that we deliver to the staff and make sure that they get more frequent interactions with us, but also we can look outside of our boundaries of our organization to help elevate, if you like, some of those who are further afield from us, not just in simulation, but also in faculty development and helping them establish it within their organizations. Because I think if for it to have impact, we need to have it integrated into everywhere where we deliver healthcare globally.
Yeah, and I remember when you mentioned Petty Stars, like they did a recent they did a national simulation faculty development workshop, and they kind of use the same module which you just mentioned. Like I was sitting in here in Miami and and kind of debriefing the debriefers. So kind of those kind of things. I think these are new things coming out of invention. This the need, and is the what's called need is the mother of inventions. So it's kind of bringing us to that point. One thing you mentioned, and I heard that was really still very worrying, that the figures which you mentioned in your talk, like 43 million patient safety events happen every year, and then there are like 23 million disability adjusted, days in the year. And then the problem, there is another issue you brought was 50%. There is more chance of 50% is more likelihood of that happen in LMICs. Can you just elaborate a little bit, like what are the immediate steps as simulation community or someone who is just starting simulation, as you mentioned, if we can address burning issues, low-hanging fruits or burning issues, what are the things which you have observed can be a good starting point for someone who's trying to reunite at this point and looking to start a simulation program, and just to show some immediate impact of what they are doing, looking at those safety events?
Absolutely. So I think it all starts with faculty development. And I'll tell you a story which as you said in your very kind introduction, I hail from Cape Town in South Africa. And I always tease, I say I live and work in exile in Bristol, planning my return to my home country. And so one of the things I've actively sought was educational links with and trying to establish simulation in a context as we imagine it abroad. And when we started that process, it started with faculty development. So at Red Cross Children's Hospital and Groote Schuur Hospital, which is a big academic hospital in Cape Town. And so we started, and what you see as you go across, the first time, well, they were all face-to-face initially. We developed faculty, they start understanding and seeing what simulation can do. And as they sort of started a small scale addressing problems, identifying mentorship. So a group of us, Peter Weinstock, a dear friend of mine, and I went across the first time. And so Peter and I mentored them in implementing some of their very small first projects and sort of being at the end of an email and everything. And then they start showing impact and then supporting them, making that case to their organization to actually address problems. And so now, and probably if you ask me what is my most, and it's not my achievement, it's the achievement of those I played a small part in their development, is that patient safety, we assume that it's everywhere. In countries where they are struggling just to keep afloat in terms of delivering healthcare, it's on the back burner because we're just trying to deal with the volume of what we're dealing. And so it's incredibly powerful that for at Groote Schuur Hospital in Cape Town, they now have a simulation patient safety advocate appointed, that's her job. And that has come directly from the simulation faculty that started testing systems, showing the deficiencies, showing where the efficiencies can be made. And so but it all started with faculty development. And that's what I mean. I think it's identifying with those individuals, the people who are invested in intelligence. Start small, build them, help them adapt it so that it works in their environment and that it becomes their own. What we don't need is organizations like mine flying all over the world and delivering courses which most of them can't afford, and then flying away and leaving them with nothing. It has to be something that inherently becomes their ownership, that they then become the catalyst. The team in South Africa that I'm working with are now reaching out into sub-Saharan Africa and establishing simulation programs in Nigeria, in Malawi, in Zimbabwe, in Kenya. Those are the impactful, I truly believe this idea about reaching out. It's world and life is about relationships. It's about building those relationships, mentoring people, helping them sort of to the next step. And I think can you imagine if all of us engage and each of us just had 2 or 3 friends across the world that we work that journey with, the impact we could have as a simulation community.
Indeed, I think that's a real, that's the whole really valid point. I think faculty development, mentorship, mentoring to those who we teach, have this long-term collaboration is what I think is the next step from our end as a community. Well, thank you, Dr. Grant. It was a pleasure listening to your talk today, and and to your thoughts and how we should come and reunite and reimagine, and how we can make our future and make the future of healthcare and our healthcare professionals better. It was a pleasure and honor to be with you today. And if anyone has any questions, please feel free, or otherwise we will be closing the session soon. Thank you very much. Kelly, you have.
Thank you, Azid, and thank you, David, for this great presentation.
Thank you.
Okay, thank you, everyone.
Thank you. Bye.
Good weekend, everybody.
You too.
Have a great weekend, and thanks, everyone.
Bye-bye.